I want to go over a few case examples just to give you a sense of how I'm thinking about this in terms of these adjacent segments or non-contiguous segments using this system. So in the first case, we have a 48-year-old gentleman who actually had worked as a stunt man. We had some discussions about this. He was always looking for work, and he would say, "Oh, do you know anybody in the industry? I really want to do more work." And we'd have these kinds of discussions. I think probably he didn't get a lot of work, but he probably injured himself over the years a bit by doing this. And he'd had 10 years of left greater than right upper extremity numbness and had a prior fusion at C5-6. His new symptoms, or maybe some continuation of his older symptoms, however, fit with really C7 and some C5 nerve roots, which really could not be ascribed to the prior level that he had done. And his more recent MRI showed T2 signal around the 5-6 level that he had had surgery on, but new 4-5 and 6-7 disc protrusions. And this was just one view of the MRI. I'm not going to show all the views and so forth, but you can see the prior fusion here looks pretty good. There are screws here and a plate. You can see this protrusion there of the disc and the one below with a little bit of listhesis. Yeah, there is something back here a bit, but when you look at the axial views, it really was not significant. So I just wanted to give you a sense of that. And what was nice about this system is I was able to go in and place this device here. This is a lateral view. So this is two devices next to each other, but they're so well aligned. Here, the disc space, you see how well open that is, the alignment here without dismantling the prior fusion. So none of this has to be taken apart. And I could get in below that as well down here with a separate device without dismantling any of the prior fusion. Here you see an AP view. You see the prior system that had been placed by a different surgeon, and I was able to get the two devices above and below that without a problem. And he did quite well. Is there a question? I think I see someone there. Is it Dr. Gupta? Is he on mute?
I don't see anyone with a hand raised, but are you getting a notification?
I saw his name, so I'll just, that's okay. All right, I'll go on to, we can do it, catch up at the end also. So case 2 was a 58-year-old gentleman who drove a truck, was hit by a car while he was on a bicycle a year prior and had neck pain in both and extending into both arms, trouble using his hand and grip, some really myelopathic types of features, and some C7 symptoms. His MRI showed both 3-4 and 6-7 disc protrusions. And to me, oddly, as we see so often, 4-5 and 5-6 involved, he really didn't have anything significant anatomically, and I would say clinically at 4-5 and 5-6. So, kind of an odd case, but you do see these. And so, here's 3-4 and 6-7 with, really a pretty decent looking 4-5 and 5-6 space. And both of them are symptomatic. I think, some of his myelopathy is certainly coming from here, I suspect, and some of his radiculopathy from down there. And so this is the kind of system that can be used quite readily for this. Normally what would you do? You'd either use artificial discs or have two separate plates. There are a lot of sort of odd cases like this that come along. And this system is fantastic for that. Again, this patient did quite well. Case 3, 66-year-old gentleman, prior fusion, 20 or 30 years prior for left arm weakness. There's T2 signal change there and did not have much improvement with that. And now has progressive myelopathy that has hand function, fine motor function worsening with spasticity in the lower extremities and balance problems that came in. So this is obviously a concerning clinical picture. And you've got this prior fusion, some T2 signal here, but very large disc right above that. Is this the kind of thing that you want to have to remove this whole plate system here and screws just to do this disc. I mean, obviously you'd rather not. There's going to be a lot of scar along the anterior margin. The esophagus is going to be involved with that. You know, yes, it's doable. I've done this in the past. Of course, it is doable, but we'd all rather not have to do it if we can avoid it. And here you can see I can get just above that plate without a problem. Here's this prior anterior plate system still in place, and then the implant that I did right above it. Very straightforward.